Okay, good morning. It's tough to be a Minnesota sports fan, and I think we all realize that this morning. But my pleasure to introduce Iulia Tulai. She's going to talk to us about mitral valve prolapse and the spectrum of disease. Iulia is a native of Romania, and she was one of the top medical students in the country. Started training there in cardiology and then decided to come to the United States to pursue her training. She started at Yale affiliate, the Danbury Hospital, and now has joined, where she was chief resident, has joined us. She's a second-year fellow. She takes fantastic care of her patients, and she's quite detail-oriented. As this case is a testament, this is a case that many of us shared in the care of, and she basically didn't know much about it and has researched it and put together a fantastic presentation. And welcome Dr. Serrano as well. All right, thanks.
Okay.
Well, good morning, everyone, and thank you, Dr. Harris, for the wonderful introduction. And just thank you for being here, because I know it's hard to be here, especially with the pandemic. And I hope you can also see the presentation, which I don't think you can. There we go. So, okay, as we mentioned already, we are going to talk about mitral valve prolapse today and see when it stops being benign. And I know that for some of us, maybe mitral valve prolapse sounds kind of like a boring topic. And apparently this is not working anymore, so I will just try to figure things out. And you might have kind of this in your mind right now, and you're going to hear about a boring topic that you maybe have heard about before, and maybe you don't really want to hear about it today again. But kind of what I'm hoping with this presentation is that maybe some of the things that I will say will surprise you, and hopefully after this you might want to even know more about it. So, before we talk more about the subject, let's review a bit what mitral valve prolapse really means. The definition is a superior displacement of the mitral valve leaflet or both of the leaflets in systole at least 2 millimeters above the annular plane. The classic mitral valve prolapse is with thickening of the leaflets of at least 5 millimeters. And one of the things that I want to point out pretty early is that when we have this prolapse of the leaflets in the atrium, there will be some tugging of the papillary muscle, which we will see will actually come up in our discussion several times today. So in 1997 was the first time that we kind of got an idea of how frequent this mitral valve prolapse really is. And the prevalence was estimated about 2.4%. Then in 2020, it seems that the prevalence is somewhere there 2 to 3% in the general population. This would mean that about 7.8 million people in the US have mitral valve prolapse, and 176 people in the world have mitral valve prolapse. And if these numbers do not really mean anything to you, just to put into perspective, it would mean that in our country, every single person in Washington state has mitral valve prolapse, or if we think about the entire world, it would be as if every single person in Russia has mitral valve prolapse. So pretty frequent, right? So if that's the case, is this something that is concerning? Is it a benign condition? Is it something that has a bad prognosis? Well, you probably know some of the outcomes really depend on things like left ventricular ejection fraction, whether the patient develops MR, whether the patient develops left atrial enlargement, and so forth. But one of the things that is associated with mitral valve prolapse, and we tend to not necessarily think about it as much, even though it's really a sad outcome, is the association with sudden cardiac death. And I'm not sure about you, but this is how I felt when I heard about this association between mitral valve prolapse and sudden cardiac death. And this reaction is, I think, the first thing that made me want to know more about the topic. So in 1966, it's the first time that the mitral valve prolapse was actually described. And until 1985 or so, we really thought it was a benign condition, maybe with some exceptions based on some publications by Barlow and Hancock that mentioned this malignant entity. but they didn't really describe the prevalence or the characteristics of these patients, so it was, let's just say, a bit forgotten. Then in 1985, Nishimura presented this study on 237 patients with mitral valve prolapse, and mentioned that in some of these patients there was development of mitral regurgitation, cerebral emboli, infectious endocarditis, and he mentioned now again that we have some patients developing sudden cardiac death, and he estimated the prevalence of the sudden cardiac death to be around 0.4% in a 6-year follow-up in the study. So despite this publication, for a while we again kind of forgot about it and maybe thought again it's a benign condition until around 2010, when a lot of publications started to happen that mentioned this association between mitral valve prolapse and sudden cardiac death. So if you're going to ask me how frequent sudden cardiac death really is in mitral valve prolapse, the frank answer is I don't know, because it really depends on many things how the sudden cardiac death is reported. So just to take an example, if we look at autopsies, for example, you will hardly ever see an autopsy that says with certainty the death was related to mitral valve prolapse. So because of that, we don't really know what the incidence is, but the numbers that are quoted out there are kind of these numbers, as you see, between 0.2% to 0.4% quoted by Nishimura, and maybe some higher numbers or lower, kind of depending on the population that we are looking at. So in 2020, there was this very beautiful review by Muthukumar, who looked at a lot of publications on this topic, dating back from 1953 all the way to 2020, and integrated in this review what they thought to be the most important publications on the topic. And they said kind of the same thing, that the sudden cardiac death in mitral valve prolapse, the incidence is around 0.2%, 0.4%, which would be about 3 times higher than the general populations, but 10 times lower than the death in hypertrophic cardiomyopathy. And I bet nothing that I'm saying so far surprises you. But the one thing that surprised me is that when we look at the actual numbers, we see that we have more people dying every year from mitral valve prolapse compared to patients dying from hypertrophic cardiomyopathy. And again, this was one of those reaction-causing things that I found, because I found it pretty surprising to see that we have more people dying from mitral valve prolapse than people dying from hypertrophic cardiomyopathy, yet when we have a patient with hypertrophic cardiomyopathy, we kind of know what to do, right? We have guidelines. We have guidelines that tell us how to re-stratify a patient for sudden cardiac death, how to treat the patient, how to prevent sudden cardiac death, and so forth. Whereas when it comes to mitral valve prolapse, even though we have more people dying from this, we don't really have any guidelines. So the obvious question is going to be, how do we really identify a high-risk patient from otherwise a low-risk population? So as I mentioned, after 2010 or so, a lot of interest was focused on this topic. And as you can see, we had 2 recent reviews on the topic, one by Miller, one by Muthukumar, which we mentioned already. And I will try to summarize some of these reviews and also integrate in this talk some of the papers that were published after this reviews. So how I organized the talk, I tried to take things from, let's say, simple to complex, and to kind of look going one by one at details, at characteristics of the patient that would suggest that we are dealing with a patient that has the arrhythmogenic phenotype or malignant phenotype. You will see that I'm using these words kind of interchangeably. So when we look at the physical exam, for example, just to make an analogy, it's not the slam dunk Williams syndrome where you look at your patient, you say that you look like Legolas, and for those of you who don't know, this is the most known elf in Lord of the Rings. You say that your patient has an elfin face, you diagnose Williams syndrome, you already know it's a supravalvular aortic stenosis, you're done. In mitral valve prolapse, the arrhythmogenic type is not really the same. You don't really have a specific physical finding that will tell you you are dealing with the arrhythmogenic phenotype. So physical exam kind of gets an X from us because it doesn't really help. When it comes to gender, a lot of studies in the past have mentioned that female sex is more prevalent when it comes to sudden cardiac death. And we see this in both of the reviews that we mentioned already. However, interestingly, if you look at the number of the patients from this study, you will see that they are pretty much low, small studies with a low number of patients. When we look at a publication, for example, by Nordhus, who looked at more patients with this condition, interestingly, they found that they have more men with arrhythmogenic phenotype than women. And the same thing in a recent publication by Dr. Zesai and Dr. Sarano, thank you, who showed that we have more men with ventricular arrhythmias, with severe ventricular arrhythmias in mitral valve prolapse than women. So, you know, the previous teaching that that women have a more malignant phenotype maybe is pretty questionable because it might actually be males. I put it here with a question mark, and maybe sex, again, is not really helpful at all. When it comes to age, kind of the same thing. We have a pretty wide interval of age when we can have sudden cardiac death, and the age per se is not very specific. There's not a specific age at which your patient is more likely to have sudden cardiac death, so it gets another X. So far, nothing really, right? When we look at EKG changes that we can have in these patients, we'll talk about two things: the repolarization abnormalities and ventricular arrhythmias. So repolarization abnormalities. Many studies that focused on this finding specifically found that we frequently have T-wave inversions or biphasic T-waves in the inferior leads. Why do we have this? It's unclear. Maybe it's related to that pulling of the papillary muscle that we mentioned earlier. Maybe it's related to regional ischemia of the papillary muscle, so not an epicardial ischemia. But nonetheless, we do have very frequently these changes. As you can see here, for example, in a study done by Cristina Basso on 43 patients that died with sudden cardiac death with mitral valve prolapse, 83%, so a high percentage of them had these changes in the inferior leads. Granted, we didn't really have a lot of available EKGs for these patients. But the same thing in a study done by Sriram, almost 80% of the patients that died with idiopathic sudden cardiac death and had by leaflet mitral valve prolapse had these EKG changes. So if we see, I'm sorry, before that, I want to show you a case that was published by Augello and Lanzarini of a patient with arrhythmic mitral valve prolapse that had an indication for mitral valve replacement. And before surgery, if you can see that the patient had T-wave inversions in the inferior leads, and interestingly enough, those changes are not present anymore after the mitral valve replacement. So if we see these changes in the inferior leads, do we put a lot of weight on this finding? And the answer is probably not, because as you can see here, up to 40% of patients with mitral valve prolapse without sudden cardiac death can actually have these inferior lead changes. But if you see these EKG findings, you might want to re-stratify your patient even more, because this frequent association with these findings for the patients that actually do have sudden cardiac death. So the repolarization changes get a question mark from us. They might be useful under certain conditions. So ventricular arrhythmias. Well, why do we have ventricular arrhythmias to begin with? And before we go into the explanations, I will remind you, which you know already, that because of this pulling that we mentioned earlier of the leaflets into the left atrium, there's going to be a pulling or a tugging of the papillary muscle. So if you're wondering if this constant pulling has any arrhythmogenic effect in patients with mitral valve prolapse, just so you know, you're not the first ones to wonder that. Dr. Gornick actually wondered the exact same thing about 34 years ago. And he investigated the electrophysiologic effect of the papillary muscle traction in the intact heart. So I will really unfairly simplify the complex work that he did, and I will just summarize. I apologize about this. I will just summarizing by saying that what he did was he used 9 dogs, open chest dogs, and he applied electrical stimuli to simulate this transient pulling of the papillary muscle. And what he found was that in 7 out of these 9 dogs, this transient pulling of the papillary muscle resulted in earlier local ventricular activations, altered QRS morphologies after this pulling, and also a relative prolongation of the ventricular functional refractory period. So the conclusion of the study was that in normal myocardium in situ, regional abnormal wall motion may be associated with alterations of local ventricular activation and refractoriness, and these factors in the diseased heart might lead to susceptibility to arrhythmias. So hopefully now it makes sense why in mitral valve prolapse, whether we have the sudden cardiac death or we don't have sudden cardiac death, we will pretty commonly see PVCs. They can be monomorphic, they can be polymorphic. Frequently, they will come from the papillary muscle region or outflow tract, probably related to regional stress or abnormal calcium handling. But regardless, if you see them per se, they are not by themselves a risk factor for sudden cardiac death. But again, if you see them, you probably should suspect that there's a lot of pulling in the papillary muscle. So maybe your patient is predisposed to more severe ventricular arrhythmias, and you want to probably risk stratify this patient even more. So more important than a yes PVC, no PVC is probably the origin of the PVC, because Said, in one of his publications, actually mentioned that the PVC origin might be a marker for sudden cardiac death. So what am I talking about? He did a study on just 14 patients, and all of these had mitral valve prolapse, but 6 of them had cardiac arrest. He did electrophysiologic study on all of them and realized, that in all 6 out of the 6 patients that had cardiac arrest in the past, Purkinje origin PVC was the source of VF when they did the electrophysiologic study. And yes, this was also the case in 5 out of 8 patients without cardiac arrest, so it's still present in patients without cardiac arrest as well. But what he did further was he ablated this foci and realized that patients had less ventricular arrhythmia after that, and reduced appropriate ICD shocks is not really on this slide, but he concluded that the PVC origin might actually be a marker for sudden cardiac death. And Dr. Zasaya and Dr. Serrano put things into perspective in their really interesting study where they looked at the presentation and outcome of patients with mitral valve prolapse and the arrhythmic mitral valve prolapse. And what they did was they divided the patients based on severity of ventricular arrhythmias. And as you can see here, that they classified as severe ventricular arrhythmias the patients with a ventricular tachycardia as more than 180 per minute and or previous ICD. And what they showed was that for severe ventricular arrhythmia, this actually associates with a higher mortality rate on the picture on the left, and with a higher composite of death, ICD implantation, and VT ablation in the picture of on the right. So this is a case published by Cristina Basso with a 36-year-old female presenting to the emergency room with palpitations. As you can see, she has right bundle branch morphology PVC, so probably coming from the left ventricle. She was admitted to the hospital, had some workup that included an echo that showed mitral valve prolapse. She was eventually discharged with a Holter. On her Holter, she had non-sustained ventricular tachycardias pretty fast, as we can see here, and unfortunately she had sudden cardiac death. This is her autopsy that revealed the mitral valve prolapse that we spoke about, and in vivo they actually showed that she had very prolonged chordae as well. And on a histopathologic exam, she had a lot of fibrosis. It's depicted in blue. This is trichrome staining. A lot of fibrosis in the basal inferior wall and in the papillary muscle. So I think it's pretty clear that ventricular arrhythmias, especially when they are severe or if they come from specific areas like the Purkinje system, are one of the criteria that we should be looking for to say that our patient has a higher risk for sudden cardiac death. So let's move on to the echo findings for these patients. And one of the first things that we'll talk about is the leaflet characteristics, and specifically bileaflet mitral valve prolapse, because a really overwhelming number of publications suggested that bileaflet mitral valve prolapse is one of the high-risk features in these patients. For example, in this study by Sriram, again with idiopathic sudden cardiac death in young patients, he saw that 42% of them had actually bileaflet mitral valve prolapse. Same thing in other studies, for example, Nordhus, Fulton, they are all proposing bileaflet mitral valve prolapse as one of the high-risk characteristics. Then in Dr. Isaiah and Dr. Serrano's publication, same thing. More severe ventricular arrhythmia associates with bileaflet mitral valve prolapse, and I will remind you that they also showed that this is important because the severe ventricular arrhythmia has more death and more composite of death, ICD implantation, and VT ablation. Christina Basso demonstrated the same thing. 70% of the patients that she looked at, 43 patients with death and mitral valve prolapse, 70% of them had bileaflet mitral valve prolapse. So yes, we will add bileaflet mitral valve prolapse to our list of high-risk features. Mitral regurgitation. So for a long time, we thought that significant mitral regurgitation is an independent risk factor for sudden cardiac death. And some of the conclusions for this were drawn from this paper by Turker. And what he did was he looked at 58 patients with mitral valve prolapse and saw in his study that the mitral regurgitation, the severe mitral regurgitation, was actually an independent risk factor for sudden cardiac death with a relative risk of 8.4. However, please keep in mind that this conclusion was actually derived from a study showing that MR is associated with ventricular arrhythmias, not necessarily death per se. Whereas Dollar looked at death per se. He studied 15 patients with mitral valve prolapse-related sudden cardiac death and noticed that 14 out of the 15 patients actually did not really have any MR. This is an 18-year-old woman, actually daughter of a physician, who 26 months prior to this picture had a sudden cardiac death, was resuscitated. After the sudden cardiac death, she had a full workup that included echo. It did not show any mitral regurgitation. And 26 months later, she had sudden cardiac death. And the autopsy, as we can see here, revealed mitral valve prolapse. But again, no MR. This is a 21-year-old patient who had the diagnosis of mitral valve prolapse ever since she was 16, and she was continuously followed for that with serial echoes, serial clinic visits. She had no MR on any of her echoes and then had sudden cardiac death, and the autopsy, as we can see here, showed a myxomatous and prolapsing mitral valve. So interestingly enough, we were talking about Turker's study that looked at the association between MR and ventricular arrhythmias. Doctors Isaiah and Serrano did the same thing, but on a larger study population. They looked at 10 times more patients, 500 and something, almost 600 patients, and looked to see whether there's any association. And at the first glance, it seems that MR is associated with ventricular arrhythmias. However, if you stratify the ventricular arrhythmias, you will see that for the severe ventricular arrhythmias, which they showed associates with more death, there's really not any association with severe MR. So again, I will remind you that the severe ventricular arrhythmias are the ones that are associated with mortality. So mitral regurgitation deserves at most a question mark, if maybe not an X altogether, based on the recent findings. So let's talk about lateral mitral annular velocities. So the famous Pickelhaube sign. What's a Pickelhaube to begin with? So it's this spiked helmet that used to be worn by Prussians and Germans in the 19th century and 20th century when they were either in the military or firefighters and so forth. And you can see that it has this spike on it. So why is this important? I will remind you that when we have mitral valve prolapse, there's this sharp pulling of the papillary muscle up towards the left atrium. However, this causes a sharp movement of the wall adjacent to the papillary muscle, a sharp movement down towards the apex. And it's so sharp that on tissue Doppler, it creates this spiked appearance, just as the Pickelhaube, a spiked appearance like this with a velocity of more than 16 centimeters per second. Why 16? Because this is what Muthu Kumar in their study referred to as the Pickelhaube sign, and it seems that if the velocity is more than 16, these patients have more malignant ventricular arrhythmias. Furthermore, when they did a correlation with MRI, they showed that all the patients who on MRI had fibrosis, they had the Pickelhaube sign. So if you think about it, it's almost a cheap way of detecting fibrosis on MRI without actually having to do the MRI. And we'll discuss about MRI later, but this is actually a very important finding, and this is why Muthu Kumar and her colleagues said that this is probably a novel echo risk marker for malignant mitral valve prolapse syndrome. So definitely this sign needs to be added to our list of high-risk features. Then mitral annular disjunction. So what's mitral annular disjunction? Simply put, it's this hole right here and here and here. And basically it's displacement of what should be the hinge point of the leaflets on the mitral annulus. As you can see, this hinge point is displaced up. And allowing for a very, very mobile mitral annulus, as we can see in this video. So that's what mitral annular disjunction means. Why is it important? Well, Carmo in 2010 showed that if you have a mitral annular disjunction more than 8.5 millimeters, it predicts the patient having non-sustained ventricular tachycardia with a sensitivity of 67% and specificity of 83%. And we saw that significant ventricular arrhythmias are a risk marker for mortality, so mitral annular disjunction is extremely important. Then Martina Perazzalo tried to see if there's any, let's say, anatomic effect of this pulling of this mitral annular disjunction, this high mobility of the annulus that we see, and not only demonstrated the same thing as Carmo, that the longer the mitral annular disjunction, the more arrhythmia there is, but also showed that the longer the mitral annular disjunction, the more likely you are to have fibrosis on MRI. So because of that, mitral annular disjunction will also be an important sign that we will talk about. And just in addition to that, I will mention that a pretty recent publication by Jegard, and I'm sure I'm mispronouncing his name, showed that mitral annular disjunction in itself, it's actually an arrhythmic entity. There is significant ventricular tachycardia even without mitral valve prolapse. This is ventricular tachycardia and aborted cardiac arrest. Even without mitral valve prolapse, and we already demonstrated that with mitral valve prolapse we can also have arrhythmias. So definitely mitral annular disjunction makes it to our list. Then Speckle tracking. So if you're overwhelmed right now with a number of things that I'm mentioning here, I hope that Speckle tracking is not going to overwhelm you, because there's a different way of saying the same thing we've been saying over and over again. Again, we go back to the pulling of the papillary muscle up that is also associated with the moving down towards the apex of the adjacent muscle. So what we see in Speckle tracking is that there's a supranormal strain, and opposite to that, there's a subnormal strain. And this actually creates the territory for an arrhythmogenic event, because if we look at how this contraction is happening in patients with mitral valve prolapse here in red, you will see there's still ongoing muscle contraction even after the aortic valve is closed here in this vertical line. There's still ongoing contraction, which is basically a setup for arrhythmia. So Speckle tracking makes it to our list as well. So MRI findings. Mitral annular disjunction again, and we spoke about it in the echo section, and I will just take this opportunity to show you the mitral annular disjunction of the patient that Dr. Harris was talking about from MHI that actually started all this for me. He had mitral annular disjunction of a very impressive number, 21 millimeters, and if you remember, Carmo said that 8.5 millimeters predicts non-sustained ventricular arrhythmia. Then Basso with Parazello said that maybe 4 millimeters predicts ventricular arrhythmia. This patient had 21 millimeters. Then curling. Well, what is curling? Curling is just let's say, side effect or something that goes hand in hand with mitral annular disjunction. As you can see here, it's not that easy to spot the mitral annular disjunction. You can see in sometimes we can see it, but not all the time. But it's very easy to see this curling, this movement up, as you can see here, that basically associates with mitral annular disjunction. And Martina Parazello showed us how we can measure this curling. Why is it important? Because it turns out that there's a linear association between curling and mitral annular disjunction, and we saw already the importance of mitral annular disjunction, so by extent, the curling deserves the same attention. Then fibrosis is probably one of the most important things that we need to talk about in this talk because, for example, in one of the landmark studies in the field by Cristina Basso in 2015, where she did histopathologic correlation for patients with mitral valve prolapse, she realized that all the patients with mitral valve prolapse and sudden cardiac death basically had some sort of fibrosis. It was 100% of the cases in the papillary muscle. Almost all the patients had fibrosis in the inferobasal wall. So really, mitral annular disjunction is a hallmark for high sudden cardiac death risk because they also showed that these areas of fibrosis correlates with the origin of the ventricular arrhythmias as well. As a response to that publication by Basso, Dr. Shepard published a very similar study with the same result. Here they had 74% of the cases with mitral valve prolapse-related sudden cardiac death having significant amount of fibrosis. Then Kitu-Kumvan took things even further and demonstrated that patients with mitral valve prolapse actually have more fibrosis than patients with mitral regurgitation, because you might have thought at this point, kind of talking about it, that maybe some of the fibrosis is related to mitral regurgitation. No, not necessarily. And the mitral valve prolapse patients have fibrosis kind of by themselves. And something else that they demonstrated is that when compared to patients here on the right with mitral valve regurgitation, the patients with mitral valve prolapse have a specific area where they usually develop the fibrosis. It's mostly in the basal inferolateral wall, as we can see here, and in areas adjacent to the papillary muscle. Then Boy in 2017 showed that these diffuse fibrosis areas actually associated with complex ventricular arrhythmias. So definitely fibrosis is one of the important things that we want to look at. So this is again our patient from MHI who, as you can see here, had fibrosis of the posterior medial papillary muscle and as well as some tiny fibrosis on the anterolateral papillary muscle and also on the mitral annulus. And it was extremely interesting that when we did his EP study, we had PVCs coming actually from the exact same areas. So as we mentioned, definitely fibrosis makes it to our list of high-risk features. And if fibrosis is so important and really can predict the patients who die of sudden cardiac death and related to mitral valve prolapse, wouldn't it be nice if we had a kind of a crystal ball and say what patients will develop fibrosis? Well, Funny enough, Dr. Miller, the same one that did one of the reviews that we spoke about, had the same question. And what he did, this was a small study published earlier this year, a small study on 20 patients that had mitral valve prolapse and already an indication for mitral valve replacement. And he did MRI studies and FDG PET in all of them and showed that in 70% of them, they actually coincided. They have both MRI positive findings of both fibrosis and FDG positive findings of both inflammation. And almost all the times, the areas actually coincided exactly as you see here. And interestingly, when they only found FDG positive results, so when they only found inflammation in these patients, they noticed that these patients had more minor ventricular arrhythmias, and I'll tell you what that meant. And when the patients only had fibrosis, so no inflammation, they had more complex ventricular arrhythmias. How they divided minor and complex, they used the Lawn scale. But the conclusion that they drew was that maybe there's an inflammatory component of the process that kind of starts the disease to begin with, and then later down the road, this inflammation turns it into fibrosis. So maybe that's why when you only have inflammation, you don't really have a lot of arrhythmia. It's simple ventricular arrhythmias. And when the disease progresses to fibrosis, you have more complex. Obviously, this is a small study. We would need more information on this, but I think it's a pretty interesting idea. And speaking of future research, there seems to be some family clustering of patients with mitral valve prolapse, and actually our patient that Dr. Harris spoke about has, his son has the exact same thing and requires an ICD. I'm not sure if it was placed already, but the son has the exact same thing. And the family clustering has been described in case reports, in pathologic series, surgical series, but we don't really have a systematic review yet, hopefully in the future. And again, speaking about the future, there are circulating biomarkers that turn to be found at higher levels in these patients with mitral valve prolapse. Again, this is an area of ongoing research, but it's very interesting to mention here. So after we put all this together and we figure out that our patient has several high-risk factors, and you'll see that maybe some of these factors that we put here as a summary do not necessarily coincide with what we discussed, because this is an older thing. You say, okay, my patient has high-risk features, but what do I do now? Well, Dr. Miller, the same one with the FDG and PET-MRI, the same one with one of the reviews on mitral valve prolapse, suggests that we could do an EP study to further risk stratify these patients. And they said what they think of a positive EP study. They define the positive EP study as a sustained monomorphic VT induced with up to 3 ventricular extra stimuli, or a polymorphic VT or VF induced to up to 2 ventricular extra stimuli. And basically what they said is, if you have high-risk features and a positive EP study, consider ICD. If you have high-risk features, but your EP study is negative, then consider loop recorder to further evaluate the ventricular arrhythmias, because we mentioned again and again that the severity of ventricular arrhythmias associates with mortality. So obviously, the treatment itself needs to go from simple to complex. There's non-invasive and medical management that we could talk about. I will be very brief. One of the important things is to avoid stimulants, and it's not really in this presentation, but it's worth keeping in mind. There are studies that actually showed that there's a higher sympathetic surge at the time when these patients have ventricular arrhythmias, and they mentioned they measured noradrenaline level, and so interesting thing that we didn't really go in. But anyway, that's why you should avoid caffeine, alcohol, tobacco in these patients. There might be a consideration for beta blockers and antiarrhythmic therapy. Unclear if it has any survival benefit though. So, can we offer catheter-based ablation? Yes, we can. There are actually several studies that looked at this, and I will briefly go over them, but basically they kind of all say the same thing. If you ablate the areas that seem to be the source of the ventricular arrhythmias, you might reduce appropriate ICD shocks, you might have a less ventricular arrhythmia burden, But this is not 100% effective because there is a moderate rate of ventricular arrhythmia recurrence. So yes, you can offer, but if you are doing an ablation in these patients, you will just diminish the risk of sudden cardiac death, but you don't completely mitigate it. And with sudden cardiac death, it's just a yes or no thing. It's not an in-between. So if you are doing ablation in these patients, you should consider putting an ICD in as well. So talking about mitral valve surgery now, we spoke about this pulling of the papillary muscle and how it has a significant role in ventricular arrhythmias. So obviously, some researchers wondered whether there's any benefit in just having a mitral valve replacement, decreasing the tension on this papillary muscle. And unfortunately, we have really limited data, but some of the data that we have is one study such as this one by Vida. It's a small study with just 8 patients, all of them with mitral valve prolapse and ICD, and they had Holter's pre and post mitral valve replacement, not Holter's, I'm sorry, the ICD interrogation. And they showed that after valve replacement, patients usually had less shocks, less appropriate shocks. So there might be a benefit in replacing the valves in these patients. This is another interesting study that is published in Indian Pacing of Electrophysiology Journal. I'm not really sure why. This is actually a Mayo Clinic study, but nonetheless, they looked at 32 patients with mitral valve prolapse undergoing mitral valve surgery, and all these patients had bileaflet mitral valve prolapse, and these patients had pre-op Holter and post-op Holter. And what they did was they divided, let's say, the patients into what they called high ventricular arrhythmias burden, more than 10%, and low burden, less than 10%. And what they demonstrated was that some of the patients, not all of them, had a significant decrease in ventricular arrhythmia burden, but usually this happened in the patients that are younger, about 42 years or so, usually the ones less than 60. So what should we conclude from this? Probably if you replace that mitral valve and release that tension of the papillary muscle soon, before all that fibrosis happens, you might have an actual benefit in kind of stopping the entire process of the disease. So in conclusions, as we went through, we saw that there are some easily identifiable high-risk sudden cardiac features in patients with mitral valve prolapse. We mentioned bileaflet mitral valve prolapse, the Purkinje origin ventricular arrhythmias, severe ventricular arrhythmias, the Pickelhaube sign, you will hopefully remember the helmet, mitral annular disjunction, Speckle Tracking, which is just another echo finding, and fibrosis on MRI, especially specific areas of fibrosis that are more frequent in mitral valve prolapse. And again, we know already that it's very, very difficult to design a cost-effective restratification model to identify these patients. So it's kind of up to us to identify them. The optimum treatment, as we kind of discussed here, is not really very clear. It's a combination of medical, interventional, EP, and surgical correction. But the optimal timing is still not extremely clear. And I know it really sounds cliche, but it needs to be an individualized treatment of your patients. The important thing is that we are aware of the condition, we are aware of the high-risk features, identify these high-risk features, and then see if further treatment is appropriate for our patient. So I will finish this presentation with what I like to call the my now and my then sort of picture or sort of slide. This is a very representative picture for actually what my childhood was. And I don't want you to imagine that Romania is all a third world country. It's definitely not. But a lot of it looks kind of like this. Definitely this is how I spent my childhood and how I was raised. And this was my then, and this is my now. So I'm not sure if I'm saying this enough, but I'm super grateful for being here. And it's really a pleasure and an honor to work with all of you. And thank you. Okay, so if you have any questions or comments, please feel free to do so.
Can
Yes, I saw you writing down things.
No, I think this is incredible because as a surgeon, we look at anatomy and maybe physiology to a point, but electrophysiology is really back of our mind in terms of patient develops heart block, refer them to EP. So if I get a patient, I've seen 2 patients last week, Leaflet prolapse, asymptomatic, and they have nearly moderate or severe MR. What should be my next line of action in terms of should I get a Holter on them or should I refer them to the EP? Because they're completely asymptomatic. From patient's point of view, if I explain them that you're at a risk of sudden death, they are not going to feel very well, for sure. So what should be my next steps, if at all, to interrogate this issue?
Great question. So I think, again, kind of going from simple to complex, you already said in the simple thing, which I'm thinking of physical exam history and so forth, there's nothing. But I would do an echo because we might easily find mitral annular disjunction. We might find Pickelhaube sign, and these are already high-risk features. And then plus minus, you might consider an MRI, but maybe before the MRI, the most appropriate thing is doing an EKG to see if you have any complex ventricular arrhythmias and the Holter. And then kind of putting all together, again, if everything sounds like you have a high-risk patient, you can either refer directly to EP for an EP study and see if they have an inducible a positive EP study, as we saw in Miller's work, or consider doing an MRI. But definitely it needs to be at least echo with Holter plus minus MRI. And depending on what comes out of Miller's work, plus minus an FDG PET scan, because we might actually not see any fibrosis because it's still early in the disease, but we might have the inflammation pointing us and suggesting to us that we have that disease is just in an earlier phase. Sure. Yes, please.
Iulia, great presentation.
Thank you.
I have 2 questions. So Dr. Babat mentioned that he saw patients with moderately severe MR asymptomatic with prolapse. I understand that the same rule of investigating the patient would apply to those only with prolapse without MR. Am I correct or not?
Not necessarily. So the MR does not necessarily put the patient at higher risk. So based on the most recent studies and pretty big and well-conducted study by Dr. Esai and Dr. Serrano and a few others that we saw already, we can almost disregard whether the patient has or doesn't have mitral regurgitation and just think about the rest.
If by accident we run into somebody with mitral valve prolapse without MR, for a simple cardiac surgeon, we should refer them to cardiologists if they are not followed.
I think so, yes.
Okay.
And we actually were talking about this recently with Dr. Gornick, and you were mentioning to me, Dr. Gornick, that there was someone with severe ventricular arrhythmias with mitral valve prolapse, no MR, and eventually the patient was referred despite not having an MR, and the classic indication for mitral valve replacement or repair had, I think, repair it was, and the patient did not have any ventricular arrhythmias after that.
And the study that you mentioned that after the mitral valve surgery, it didn't specify whether it was repair or replacement, the ventricular arrhythmia burden goes down.
Yes.
And then doesn't matter whether you replace it or repair it, or does?
That part I do not know.
Thank you.
Yeah.
Maurice, what's your perspective on all this?
Well, it's very good because I'm very confused still. So I think it's a very important consideration. The prolapse is getting you weird because first, all the literature before '89, when we changed the criteria for diagnosis, you have to throw it away. And then, you had that sort of dance of, oh, it's not much, it's just auscultation abnormality. And then, oh, everybody dies suddenly. And, oh, it's benign. The paper from Framingham saying it's benign. and then we say it's heterogeneous, but mostly benign. And then now you have my former colleagues at Mayo saying, one of my former colleagues saying, oh, it's malignant. And you say, okay, I don't know where I am. And so it's very difficult because to understand the literature. And very often you have those small series. The Pickelhaube sign, 21 patients. 67% sudden cardiac death in one group. And you say, whoa, I'm not sure I can use this sign now, 21 patients. So we put it aside, we'll study it, and we'll see if it deserves more attention. We know that mitral valve prolapse overall, if you take everybody, no MR, normal EF, they have a benign outcome. They live as long as the general population. So that's the sort of overall. But it doesn't mean that in there is not a small group that may be at high risk, a small group. So the first thing that we did is to say, okay, is it that you die suddenly because of the mitral valve prolapse, or you die suddenly with the mitral valve prolapse? And the pathologists are all excited. They find the mitral valve prolapse. Oh, I found it. Say, yeah, a lot of people have mitral valve prolapse. Is it the mitral valve prolapse causing the death? So one of the first things that we try to do is to say, okay, if you take the people with arrhythmia, do they have a common phenotype? Because if it's a random phenotype, then it doesn't mean that it's linked to the mitral valve prolapse. If it's an organized phenotype, then you can link the arrhythmia to the mitral valve prolapse. And the phenotype is a sort of advanced myxomatous disease with bileaflet prolapse most of the time, not all the time, but also thickening of leaflet, high mobility, and the mitral annular disjunction, which is a very important feature, because you have that the annulus is not anchored anymore in the wall, and it falls down each ventricular contraction. So it's like having rupture of a tendon. You know, you contract your muscle, but it doesn't pull on anything. And that's why we saw on the MRI was beautiful, because you see that sort of pulling on nothing, and the muscle is big, but it's because pulling on nothing. And so if you have that because we found that that sort of uniform, you see how the muscle densify at the base? It's because it's pulling on nothing. It's not attached to the mitral annulus, which is the sort of crux there. And so you pull, it looks really strong, but in fact it's just pulling on nothing. So that's a very important feature that we saw in those patients. But so it seems like there is a phenotype, and now we know how to identify the people at risk, because you do a Holter, you find VT of more than 180, you know it's a small group, but it's high risk. The intermediate, the arrhythmia, you find a few extrasystole, non-sustained VT, but not fast. We don't know if it's serious. So there's a small group that is that seems to be serious. And I think that one of the major conclusions is to say, okay, in the guidelines, there is no word about Holter. So I think that we need to look for arrhythmia more, because we haven't looked for arrhythmia, and have more evaluation for that. And so so we think it's true that there is an arrhythmic mitral valve prolapse with that phenotype of extensive myxomatous disease that you identify by doing the monitoring of the arrhythmia. And then these people need treatment, and it's very difficult when you have those high-risk ventricular tachycardia. What are you going to do? There's no trial. So Sam Asirvatam, you know, he can ablate anywhere. So he goes at the tip of the papillary muscle, buzzes the thing, bzz, and or close to the mitral annulus, maps the arrhythmia. Is it the way to go? The surgeons, they're doing something which is interesting, is they correct the mitral annular disjunction without knowing it. Because they're in the atrium, they don't see the annular disjunction, the heart is flaccid, it would take a lot of time to see it. But when they put the ring, they attach to the muscle, and so they reattach. And so the mitral annular disjunction goes away after repair, and the arrhythmia seems to decrease. So grossly, what we had in mind is to say, okay, if there is moderate or moderate severe MR and you have the arrhythmia, do a valve repair. If there is not much MR, think about ablation in people who have severe arrhythmia. And we don't know if you should be placing ICDs in everybody. So the only conclusion is more work. Do more Holter, do more monitoring of arrhythmia, and then have more data on long-term outcome. I think that here there is a pretty good collection of MRI with mitral valve prolapse. I think that the count that I had was on the more than 100 patients. That story about fibrosis, you've seen the work of Basso, it's 40 sudden death and 16 controls. You say, what can you say with 16 controls really? Is fibrosis occurring in the same age? And they talk about prolapse with sudden death in young patients, which you don't see that much because prolapse is something that comes with age. You know, you see a few dying young, but prolapse increases with age. So there is a ton of work to be done. So we need to work more.
So, I mean, that was an incredible review, Iulia. Thanks so
you.
much for doing that.
Thank you.
I guess, as in this family, you know, I actually met the patient on a Saturday and I gave my card to his family members and actually, you know, the son is identical. So he's actually he has complex active his repair. So I think in his case with the dad, you know, having these sudden death type episodes, it's relatively easier. But I think, what about in the other patient that has bileaflet prolapse, has some fibrosis, you know, mitral annular disjunction, ventricular ectomy? Do we have enough evidence to put ICD in that sort of patient? And would a ablation be good enough?
But that's only the way to build evidence, right? Because one of the studies you showed, the number of shocks, it's one of the ways to look at it is, are we doing things right? For aortic stenosis, for example, asymptomatic case, we take velocity, say, higher than 5.5 as one of the indicators now to intervene. And I think this is pretty complex. It's a chicken or egg situation. What should we treat first, and is it too much? And no intervention is without implications. But this is from at least what I understood is, if I see a patient, for sure I should flag it up and maybe send him or her for MRI and ask EP to have a look at it. From history point of view, how we can elicit that patient has something? Is it just palpitations, or because that's the main thing for me, for sure.
I think if they had palpitations, it might help, but we know a lot of patients have palpitations with sinus rhythm, with anything, so I'm not sure if we should put so much weight on it, unfortunately. And history might not be extremely helpful unless you have a syncope that you can say maybe it was a ventricular arrhythmia. Otherwise, I think from symptoms point of view, you don't really have anything that really helps.
I feel I must make some comment.
Yes, thank you, Dr. Gornick.
Very nice review.
Thank
I
you.
think from an older physician who's been looking and following this for some 40 or approaching 50 years, our knowledge is progressing. I do think several things from an electrophysiology standpoint. Mechanical factors and a surgical standpoint, mechanical factors are important in mitral valve prolapse and cause the fibrosis. In fact, some of the trouble with the pathology studies are all the patients are dead, right? I mean, so you find something and they're all dead. So, you know, they describe endocardial friction rubbing just from the 40 rubbing on the endocardium, and actually you could see those in some of the pathologic specimens. Having said that, though, the mechanical factors must be important in some patients. I mean, we've had patients who had pretty severe bileaflet prolapse, and as those studies you pointed out were either valve replacement or repair, they had substantial reduction in ventricular arrhythmias, and so they went from having ICD shocks to not having ICD shocks. I mean, that's difficult to reconcile if you don't think about that. There are other patients with mitral valve prolapse, and I still think it might be mechanical because they'll snap a cord. Now, some of them will go into pulmonary edema, right? And you'll see them and they'll come into pulmonary edema. But others won't go into pulmonary edema, but they'll actually have a cardiac arrest. But I think what happens there then is you've again changed the mechanical forces. I mean, suddenly if you snap a cord or two and you have other cords then pulling a lot harder, it just makes sense that may actually be a contributing factor also. I do think, the way I looked at it for years is it's like you got this huge Venn diagram of mitral valve prolapse and you got another circle with sudden cardiac death. And there is this small little sliver in between that matches. And it's our challenge to figure out who fits in that sliver. And it's not all that easy. Last comment I'll make about EP doctors and putting in ICDs, you can put them in, but they have complications, so you hate to put them in just for nothing. Ablation is we've done ablations in these patients. It's frustrating. If they're all under Purkinje, I tell you, we'd be much more successful than we are. The other thing is we're very careful about ablating significantly in the papillary muscle. Think about it. You already have fibrosis there. You already have mechanical pulling. Now you're going to go down there and you're going to cauterize the by Jesus out of that papillary muscle. It just doesn't seem logical. Doesn't seem logical to us. Just doesn't. So those are my comments.
Thank you. And Dr. Landy also thank you so much, Dr. Bernick. Dr. Landy, I think you had a question.
How often the sudden death occurs during exercise?
So there is a study that looked at athletes, and most of their death happened when they were exercising, and they're actually saying between 2 and 4%. And we are usually talking about a prevalence of 0.4%, and that study quoted 2 to 4%. But
very difficult.
I'm not sure if it's so answering your question, but that's the only analogy that I can make. And I know that some studies said that they are more frequent when they exercise, but I don't know the exact number.
The sudden death, we had the registry of sudden death international, so 42 sudden death where there was only the mitral valve prolapse. So it's not much but there is no clear link to exercise. We don't understand exactly how they produce this arrhythmia.
Yes.
Thank you very much. We have several online questions. Some of them are fairly similar, so I'll do my best job to consolidate here. But the first one is, should we be more aggressive in our timing of surgical repair of MVP patients to avoid arrhythmias and fibrosis/inflammation effects? So I don't know if you need to repeat that.
Yes, so kind of as we said in the conclusion, I think it's very hard to give a general answer because we don't really know what the other risk factors are. And I think it really varies from one patient to another, and that's why I use that cliche with individualized approach, because as we mentioned several times this morning, it's very hard to even make that commitment to change or repair, replace a mitral valve when it has no mitral regurgitation. So I think if I had that patient, I would look at other things like fibrosis, like the amount of ventricular arrhythmias and so forth, to make that decision based on more data than just yes or no, fibrosis, no fibrosis, or MR, no MR.
Just
yes.
comment on that. The moderate MR has a small but definite risk. So if you have a patient who has moderate MR that you wouldn't operate normally, the fact that there is arrhythmia may push you to do the surgery a little earlier if you can do a valve repair. So low risk operation and restoration of life expectancy by the repair. then yes, it expands a little bit, the arrhythmia expands a little bit the repair section to the moderately severe MR.
Just one last thing, we didn't talk about it, or you didn't talk about it, but if you have mitral insufficiency related to mitral valve prolapse, you do see significant left atrial enlargement. And atrial arrhythmias and atrial fibrillation is not inconsequential. And exactly how that fits into this mosaic, I'm not sure. But it is a natural history part of that disease process. And that shouldn't be underestimated, because again, if we had better ways to treat people earlier, could we actually change the natural history? Now, a valve replacement obviously is not. Now you have a different clinical problem, right? Versus a repair or something like that. So
That's such a good point, because it's unclear if it's related to sudden death, but the atrial fibrillation is still a class 2 indication in the guidelines. And when you look at the mortality associated with atrial fibrillation, it should be a class 1, even paroxysmal atrial fibrillation should be treated as an immediate indication for surgery. That's a very important point.
Yes, John.
Yeah, so there's just two more questions. Actually, one is from Dr. Cavalcante, so
We can skip that one, because actually, the question was about, the differences in arrhythmia reduction between repair and replacement.
Mhm.
I guess that's very, provocative, but I don't think we have that data enough to.
I actually don't. Maybe I should have looked, but I did not look at that part. I did read the article. I do not remember if they actually quantified. I think they kind of put it together, but I wouldn't take my.
I can tell you, if it's the repair bandwagon, they will say repair is much better.
No, that,
But
yes.
it means physiologically, if you're,
Yes.
one of the things you said is why prolapse causes the
Pickelhaube.
Pickelhaube sign is the stress on the papillary muscle.
Mhm.
Now, replacement, in theory, even if when we preserve the posterior leaflet, should take away that stress.
Right.
Because the closure is now on the artificial valve and not on the native valve. Even if you take the prolapse out, which I assume if there is no regurgitation, I don't know what kind of repair people will do, but whatever that is, it would still have that susceptibility for stress on the papillary muscle.
Right.
So I'm not sure how that would play, but I'm pretty sure, knowing surgical literature in the last 20 years, the conclusion from whatever will be repair is better than
Right.
replacement. So I think probably more data is what we need in these patients in the trigger for that fibrosis and some of the basic things.
Right. Right. Thank you. Yes, John.
last question, I promise.
That's okay. I enjoy them.
So this one asks, should everyone with mitral valve prolapse have CMR and metabolic PET?
I bet insurance companies.
Who did you pay to ask this?
So I'm sure that the insurance companies would be very happy if we did that, and the patients as well. So that's exactly the problem. We don't really have a good way of re-stratifying these patients that makes sense from a financial standpoint. And well, I would say yes, they should all have MRI and PET at the same time, just so that we can continue that work that was started by Miller. Started by Miller. But honestly, no, I don't think everyone should have MRI. I think there's a lot of other things that we should be looking for before we look at MRI, like we mentioned on the echo and Holter, so things that are very, very easy to obtain and that give us a lot of data.
I think, if I may just make the point, if you have nice prolapse disjunction, then ventricular arrhythmias, you actually look into the substrate. So you're building up the case, even so the decision for mitral regurgitation as well as quantification. So there is an added value, but not for every single patient.
Right.
That's sort of what I've been doing, and then, but if the more you look at it, the more you see mitral annular disjunction, right? I mean, so you can kind of, you don't want to be doing it on 2% of our population.
Yeah.
just think about that though. If you have a mitral valve that's mapping because of its redundancy for years and years. I mean, it's gonna stretch stuff, and, you know, that's why that angular disjunction occurs in my mind. And so it's gonna be commonly present, but it doesn't necessarily tell you that, oh boy, this is somebody that needs an ICD. It's just, I mean, the people that need ICDs have it, but all these other people don't necessarily need one, and that's the challenge.
Thank you all, everyone.